Welcome to Prepare Tennessee LTC, a podcast created to provide resources and information on the current topics experienced within Tennessee long-term care and skilled nursing communities. I'm your host, Rachel Turner, an Associate Program Manager here at Vanderbilt University Medical Center's Program in Disaster Research and Training. I'm joined again with Dr. Mohana Karlekar, a Section Chief of Palliative Care Medicine here at Vanderbilt University Medical Center. Please join me in listening to her presentation on palliative care.
In the first podcast, we talked about what palliative care is, a little bit about the barriers in individuals trying to access healthcare and make a plan that works for them, and disease trajectories. We talked about the importance of having conversations and engaging in dialogue about what's important, which leads us to our next topic that I really want to talk about, which is advanced care planning. We are going to talk in this podcast about the different advanced care directives available in Tennessee, how these documents work and the key components. And hopefully by the end of the discussion, you'll have a better understanding of how to use these documents and which one or maybe both are right for you or your loved ones or the people you're taking care of. So I'd mentioned in the first podcast, the patient I'd taken care of, Mrs. W. And just as a reminder, she's an 80-year-old woman when I first met her with just some high blood pressure and an underactive thyroid. To chronicle her medical history, by her late 80s, she'd become widowed and began to forget more and was eventually diagnosed with some very mild dementia and went from an independent living facility to an assisted living facility and ultimately a memory care. And throughout this path, while she first had the ability to make decisions, she had her living will, which we revisited. And ultimately, she had documents that were utilized in her assisted living facility as well as memory care and independent living facility that reflected her wishes. And so we'll talk about those documents and how important those documents are, not just for people like her, but anyone living in any kind of long-term care facility as a way to make sure we are communicating the preferences we have for ourselves to the people who are providing our care. So let's first talk about advanced care directives and define what that means. And this definition comes from the Patient Right Council. Advanced care directives is a document by which a person makes provision for healthcare decisions in the event that in the future he or she becomes unable to make those decisions. And I would argue that advanced care directives are really more than just a document, but it's the conversation. It is the discussion, not just with your healthcare provider, but also with patients and families about what you want as things change in the future. So I think the unfortunate reality is that we as human beings tend to avoid what we feel uncomfortable about. And most people don't want to talk about advanced care directives, or at least that's what physicians perceive. And so doctors don't always have conversations about this. Maybe sometimes the conversation is uncomfortable for the physician. And I think the physician sometimes worries that having the conversation means that we're talking about death and dying. But in reality, having the conversation is really the way you make sure what you want happens. It's your insurance policy. So it's important to have these conversations and not avoid them. When you look at statistics across the nation in terms of what we see with patients relating to advanced care directives, we know that about a third of Americans will see more than 10 physicians in the last 6 months of life. We know that less than a third of Americans have advanced care directives. And in one study, we found that 25%, so just a quarter of physicians, knew their patients had an advanced care directive when it was completed. So we have a lot of work to do in trying to have conversations, get these documents completed, and then shared with the appropriate people, whether it's patients, families, and healthcare providers. So this slide is another way to think about advanced care planning. And it is thinking about this as a process, not as a one and done. So the first thing we like to have patients think about, whether you're a resident of a memory care or at home, who would be the one to make decisions for you if you were unable to make decisions? And then from there to have people reflect on advanced care directives, to have conversations about what we call goals of care. In Tennessee, we have a form called the Physician Order Scope of Treatment, or POST, and then really engage in end-of-life decision-making when people are near that end. So all of these constitute advanced care planning. In Tennessee, we have two major directives, and we'll discuss these both today. One is the Advanced Care Directive for Healthcare. It used to be called the Advanced Care Plan. The Advanced Care Directive for Healthcare has the ability to name a healthcare agent and also has a living will portion there. This document has to be interpreted by a healthcare provider, and it is a document that you use for the future when your health changes. The post form, also called the physician order scope of treatment, this is a document that a patient can fill out if the individual does not have the capacity to make decisions. For example, they have Alzheimer's disease, dementia. A family and a healthcare provider can fill this document out still. This post form is a medical order, so it is not subject to interpretation, and it is valid in all the community settings, including emergency departments, long-term care facilities, dialysis centers as well. And it's valid now. So let's talk about these two documents a little bit more in detail. This is what the document looks like in the Tennessee Department of Health website. I work at Vanderbilt, and they've turned this one-page, two-sided document into something that's 4 sides. And I'm going to show you our version just because it's a little bit easier to go through as we break it down portion by portion. So the first part of the Tennessee Advanced Care Directive for Healthcare is naming your healthcare agent. And again, a healthcare agent is an individual that a person decides or designates on who would make decisions for them if they themselves could not make decisions. What I always let people know is that when you are naming your agent, you want to make sure you name someone who would make the same decisions you would make for yourself. If that person could not make your decisions, do not pick them. In this Tennessee document, there is a place for an alternate agent. So you can name one person or two. The order matters. So the first person you pick is the first person they will go to. If that person is unable, then they'll go to the alternate agent. The bottom of that page has 2 checkboxes. When is this document effective? Is it effective right now while the individual has the ability to make decisions, or is it valid only when the individual loses the ability to make decisions? I truthfully do not know why these 2 checkboxes are here. I would encourage everyone to make your own decisions while you are able, and when you're not able, if you don't have the ability to make your decisions, then have your agent, and that would be checking off the bottom box. The second page, and this is where the form gets a little bit complicated, and the form is complicated, but when it's done right, it's a really, really good form. The second portion talks about quality of life, and it asks someone to think about what would be an acceptable quality of life and what would not be acceptable. And out of these 4 descriptions, and we'll go through them one by one, if any of these qualities of life are unacceptable, then you check off no. And what that indicates is you would be unwilling to live in that state. And just to emphasize, all of these qualities of life are permanent. It's that we can't get you out of this state, and this is the best we can get you. The first state is permanent unconscious condition. And for those of you who remember Terry Schiavo, that is permanent unconscious state or coma. People are alive, they are able to breathe, but they're not able to interact with the world around them. They're not able to talk, they're not able to move around. And in this state, like all these others we're going to talk about, they're never going to get better from this state. So the question is, would an individual find this acceptable or not? If it's unacceptable, you check off no. The next condition is permanent confusion, and this is something typically we see with advanced dementia, cancer that's gone to the brain, multiple strokes, etc. And this is someone who is able to perhaps talk but not remember, not make sense, not carry on a cogent conversation, not be able to make sense of what is being said, or even be able to left alone. So this would be permanent confusion. The next condition is dependent on all activities of daily living. And activities of daily living are the things that we do to take care of ourselves. So that's bathing and dressing, feeding, walking. And if this state refers to not being able to do any of those things, so if you can imagine being in a bed and not being able to get out, where someone has to feed you, bathe you, dress you, and toilet you. The last one is an end-stage illness, which has reached its final stages despite full treatment. So examples of this might be end-stage cancer, where we have no more treatments, or end-stage heart failure, where there are no other things that we can do. So in this portion, again, going back to these 4 qualities of life, if you are the individual filling out the document, you want to decide for yourself, if you are in this place in a permanent way, is this a quality of life that is acceptable or not? And if it's not, that indicates that you would not want life prolongation in any of those states. Now, the third portion of this document talks about treatment. And the treatments they're referring to are treatments for the future if you are in a state that you said was unacceptable. It is not referred to now, it refers to the future. So if you said living in a coma, that first category, was unacceptable, these questions are really referring to what you would want in that condition. So the 4 treatments they talk about are the 4 categories of treatments. The first is CPR, and CPR is cardiopulmonary resuscitation. I like to point out that CPR is not what we do when people have a heart attack. CPR is what we do when someone's heart has quit beating, your blood is not pumping, and someone has actually died. It's trying to revive someone and get them back to life. In patients who have chronic illnesses and patients who have advanced cancers, we know with the medical literature that survival and getting back to your former life after CPR, the rates are not what you see on TV. Survival on TV looks amazing. It's just not like that in real life. The second category is life support, and life support includes breathing machines like ventilators, dialysis machines, any machine that could support your organ. Third treatment is treatment of new conditions, and those are things like antibiotics, blood transfusions, and the last category is tube feeding and fluids, which is artificial nutrition hydration. So again, when you're looking at these treatments, it's not the question of whether you want these right now, it's the question of whether you would want these if you were in a condition where your life is unacceptable. And then the last part is organ donation, and then the signatures. The signatures in Tennessee, you can have 2 witnesses, or you can have a notary. And right now, with the COVID pandemic, there are electronic notaries available. So that's the Advanced Care Directive for Healthcare. Let's move on now to the physician order for scope of treatment. This document, just for people to be aware of, is called Other Things in Other States, but in Tennessee, we call it the Post. This is a Vanderbilt version of the form. Again, you can get this on the Department of Health website as well as other sites. The first portion of the post form refers to CPR, which is again cardiopulmonary resuscitation. And the question is, would you want an attempt at resuscitation or would we not attempt resuscitation? Section B is a set of questions that asks an individual or their family what indication we would get someone back to the hospital. And I think for people living in long-term care facilities, this is incredibly important. Do we bring you back to the hospital and try every treatment available, including ICU, breathing machines, etc.? And that would be that bottom category, full treatment. Do we bring you to the hospital only if we can't make you comfortable? And that is someone who has an end-stage illness, which we can't make better, and that would be comfort measures. Or the in-between, do we bring you to the hospital to try to treat easily reversible conditions, things like antibiotics for pneumonias and water pills to get the fluid off, but avoid the ICU? And so these 3 categories, comfort measures, limited treatments, full treatments, allows an individual to decide what kind of care they want should they need to be in the hospital. The section C talks about artificial nutrition hydration. And generally there are 3 categories. Is it, do you never want artificial feeding? Do you always want it, or do you want it defined? And in general, if people are not sure, I generally counsel them to pick the middle one, which doesn't box you out of any category. This document, like I said, is ideally discussed with the individual patient, but if the patient doesn't have the ability to make their decisions because they have something like dementia, then this can be discussed with a family member. The form, when you fill it out, you write out who you filled it out with, and was this based on a living will, the patient's best interest. The physician must sign the document. The patient and the family, we like to sign. They don't have to for it to be valid. And this document, like all legal documents, stays valid until it has been either replaced or revoked. And again, this document is valid in the emergency department. It's valid in community centers like your assisted living, your long-term care, your dialysis center. It is a really good document to have when you are sure what you want and maybe you're not sure what people will do in your family. And it provides clarity and a good roadmap for them. I used to watch Scooby-Doo when I was a kid. And the funny thing about Scooby-Doo is no matter who he was up against, he survived, which is incredible. And unfortunately, the world isn't that way. We know that we're all born into this world and one day we'll die. And the important thing is really being able to have conversations about what is important so we can empower ourselves and make sure that the decisions we want for ourselves will happen even when we don't have the ability to make those decisions. And that's why advanced care directives are such an important piece. Going back to my patient, Mrs. W., in the beginning, when she was able to make her own decisions, she was very clear about quality of life. She was very clear that she wanted to be independent and able to do for herself. And she really wasn't thrilled about moving out of her house, even though she knew from a safety standpoint, she just had to. At the end of her life, her family was very clear on supporting her wishes, understandably having a hard time coping. She was a lovely woman because nobody wants the person you love to die. But we were sure to make sure she had her post form set up in the last, I would say, 6 years of her life, reflecting what she wanted, meaning she didn't want feeding tubes in her case. She wanted to come to the hospital initially and not go to the ICU. And ultimately, the decision was come to the hospital only if she could not be made comfortable where she was living. And so this document was pretty instrumental, not just in making sure she got the care she wanted, wanted, but I think also with many of our family members who lived across the country, that as we filled out that document, I think it was a wake-up call to say, like, gosh, this is really happening. And so there are lots of different benefits for these documents. Just to say a little bit about coronavirus and the importance of advanced care directives. Advanced care directives are always incredibly helpful because it's a way for us to communicate our preferences. For a physician, it's a way for them to understand what our patients want. For families, it's a way for you to ensure that you are doing what your loved one wants. Because ultimately, when we deliver healthcare, we want to deliver healthcare that is consistent with someone's goals and wishes. There are a lot of people who are afraid to come to the hospital because they're afraid of dying in the hospital. Some people are afraid because of what they saw on TV. And I've had people make decisions a little bit differently right now with coronavirus than they would have a couple of years ago with the other illnesses that they have been dealing with. And so I would argue that even if you think you know what someone wants, whether you're the family member or the healthcare provider, now's a time to go back and really ask. It's important to not make assumptions and make sure that we are precise on the expectation of what people want. And then in those same conversations, it's an opportunity for us as healthcare providers to talk about how realistic those wishes may be, because sometimes we are just not able to survive like Scooby did it every time. And so giving people the perspective, the expectations, and a realistic outlook on what is possible is going to be really vital to both patients and families. My takeaway messages, I think, with this podcast are really advanced care directives are incredibly important to have. I would argue that you can't ever be too young to start the conversation. But as we get older, as we change in terms of our health, as things in our life change, whether it is losing a spouse, moving into an assisted living, transitioning to memory care, these are all opportunities to have conversations. If we don't ask the question, then we don't know what an individual wants. And so avoidance is not a great way to deal with this. When we do have the conversation, in particular, if we're dealing with an end-of-life issue, I think the part that gives everyone peace is knowing that we did what somebody would want. And the way we do this is through really good advanced care planning.
Thank you, Dr. Karlekar, and thank you to our listeners for joining us today. If you have any questions regarding palliative care or anything that was mentioned in today's podcast, please visit our website at www.emergencyltc.org.